Good morning, everybody. I think everybody's now joining the call. Can see everybody's on mute and cameras off. I'm not sure if you are able to turn your cameras on, but you are welcome to do so. But if you could keep on mute, that would be much appreciated. So we've got quite a few people joining, but I will kick off because we've got quite a tight agenda today. I can already see lots of friendly faces joining. Well, I can't see faces, but I can see a few names, which is really nice, and a few new people too. My name's Jez, and I'm going to guide you through today's agenda. My primary role at CSU is to connect the dots across our different projects with employers, the NHS, public health, research partners, and a myriad of different organisations as well. Today's session is about workplace health checks that deliver prevention at scale, and more specifically, the lessons learned from delivering the DHSC workplace CVD health checks pilot, which is a bit of a mouthful, with Cambridgeshire County Council, Solihull Council, and JLR. Before we start, just a few housekeeping points. The session will last about 60 minutes with time for questions at the end. Please keep your microphone on mute. You're welcome to add questions in the Q&A function as we go, and we will address as many of those as we can at the end. Today's session is being recorded and we'll share the slides afterwards. If you have any technical issues, please try rejoining or let us know in the chat. In today's agenda, we have Paul Stokes from Cambridgeshire County Council, John Ford from Solihull Metropolitan Borough Council, and an employer's perspective from JLR's Carol Pulfer and Chris Milton from Health Partners. And my colleague Samantha Fay and I will follow with a short overview of our learnings and CC's future roadmap as a consequence. We'll close with the Q&A, where you can put questions to the panel. And as I said, please add these to the chat as we go. Before we go any further, I'd just like to say a few heartfelt thank yous to all the partners involved. The pilot's brought together a wide range of stakeholders from national programme level through to local authorities, public health teams, and onto employers operating in very, very different workplace environments, and quite a few other stakeholder groups in between. That range of involvement's been important because what you hear today is grounded in real delivery across multiple contexts. But I'd just like to call out a few delivery partners we've worked with before we proceed. The Solihull pilot led by John was highly complex, and John and Carol will talk about this shortly, but I just wanted to highlight Solihull Health GP group that worked very intensely and kept us on track. And also health partners who led the project from end to end, and it really was quite a complex project beyond just what we did for the pilot itself. Both partners were really, really supportive and been an exceptional example of how industry, the NHS, public health can come together. And with regard to the Cambridgeshire pilot, we had a somewhat different model that really required some close collaboration, obviously with the council team, but also with Everyone Health, the provider, who were exceptionally supportive, particularly given the compressed timelines, which I know everybody experienced that was involved in the pilot. I guess the key message here really is that this was a system-wide effort, not a standalone intervention, and perhaps a precursor to an extended version of the upcoming neighbourhoods. Just very quickly, I want to talk about CSU's role in the pilot before we move into the core presentations. So set context, our role really was to enable workplace delivery in practice. We provided the infrastructure that allowed local authorities to deliver checks inside real workplaces, supported different delivery models, engaged with employers and working age populations, and to generate consistent data across partners. The CSU platform, or ecosystem as we often describe it, combines a classic self-service health kiosk, which I believe many of you will have seen, which we describe as the MAPS, and also a mini version, which, funnily enough, we describe as the Mini. We have online platforms for users to access the results, behaviour change programmes, there's a bit of gamification, some other content, and we also have data transfer, signposting of pathways to service providers and GPs. And this is overlaid with data analytics platform for commissioners, and we'll touch on some of that data a little bit later. So What I'd like to do now is to introduce you to Paul Stokes, who will move forward and tell us about what Cambridgeshire County Council did and what was also a very, very complex model. Over to you, Paul.
Thanks, Jez. Morning, everyone. My name is Paul Stokes. I'm a public health principal at Cambridgeshire County Council, and I'm the lead for cardiovascular disease, including the commissioning of the NHS Health Check programme. So I'm going to talk through our experience of delivering the workplace cardiovascular disease checks as part of the DHSC workplace pilot that Jez mentioned, and the use of the CSU self-service health kiosks as part of that programme. I'll focus on what we learnt about impact, reach, access, feasibility, and when you try to do this across lots of different workplaces rather than one setting. So this isn't a perfect model. It's about what's realistic for local authorities working at scale with real employers and real constraints. Next slide, please, Jess. So Cambridgeshire is a very large geographical county. There's a slide on the screen that shows you where we are. The pilot covered both Cambridgeshire and Peterborough City as part of the bid. To put that in context, Cambridgeshire is just over twice the geographical size of Greater London, but has only 1/10 of the population. So that geography really matters when you're thinking about access and delivery of health improvement and prevention programmes. From the outset, we wanted to make sure the delivery was spread across all 5 districts of Cambridgeshire, as well as Peterborough City, because we take a place-based approach in Cambridgeshire. We also have a very mixed local economy. Alongside some large employers, we have many medium-sized businesses, ranging from factories, food manufacturing, logistics, through to biotech and electronic sectors in the Silicon Fen area of Cambridgeshire. So we deliberately chose a multi-employer approach. The aim was breadth rather than reach, breadth rather than depth, and a single flagship employer. That's why we tested the feasibility across many different workplace settings, and you'll hear about JLR's example of a single flagship employer in the next presentation. Next slide, please, Jez. So what we already knew wouldn't work. We came into this some very clear learning from the existing community outreach NHS Health programme. In particular, we knew that delivering full 20 to 25 minute face-to-face NHS health checks directly in workplaces was a significant challenge, especially in production line and large shop floor environments. For many employers, taking staff off production line for that length of time wasn't workable. And in previous attempts, we received a lot of resistance, even when employers were supportive of the idea of health improvement programmes in workplaces. So we needed a model that reduced time, reduced disruption, and still added health outcome values. Next slide, please. So how the model worked in practice. The self-service health kiosk changed that dynamic and our approach to delivery. As checks took around 4 to 5 minutes and machines could be placed in communal areas such as canteens and staff areas, that meant people could use them before work, after work and during breaks, and they were available 24 hours a day, 7 days a week. Crucially, this didn't disrupt production or day-to-day operations. For employers, that was the turning point for us. For staff, it removed the need for appointments or taking time out of their working day. Next slide, please. So this was never intended to replace the face-to-face NHS health checks, but to complement and support. We saw the kiosk as a front door. If a check identified risk, people could be signposted to our Healthy You behaviour change service or encouraged to take up a full NHS health check if they were eligible. Importantly, people could opt in for be directly contacted for follow-up to have a full NHS health check in their own time at a location close to where they lived or worked, or through our Healthy You behaviour change service. So that flexibility really mattered for employers and also for the individuals. Next slide. Scale and uptake. So in terms of scale, demand exceeded our original expectations. So the pilot took place over a relatively short period, as Jez said earlier, from mid-October 2024 to the end of May 2025. So just over 7.5 months, or 230 days, including the Christmas period. Within that time frame, we had ambitiously targeted about 12,500 checks and actually delivered over 15,000 self-service checks across roughly 55 workplaces. Once a machine had been in a workplace for 1 or 2 weeks, we tended to move on to maximise reach and value for money. At that level of throughput in a relatively compressed delivery window really showed us there was pent-up demand once access barriers were removed, and that this kind of model was operationally feasible at pace and scale. Next slide, please. So who were we able to reach? This approach helped us reach groups often missed by routine routes through the traditional NHS Health Check offer. In terms of gender, uptake was close to parity, with around 47% of men, which is notably higher than what we typically see in a face-to-face NHS Health Check participation locally, where male uptake is consistently and significantly lower. In addition, about 1/3 of users came from the most deprived socio-economic quintile, which tells us the model wasn't just appealing to the worried well. We also reached a much younger cohort. The median age of users around 39, compared with the national NHS Health Check average in Cambridgeshire, which is closer to the early 50s. Because the self-service checks weren't restricted to the 40 to 74 age range, we were able to engage working age adults under 40 and start identifying emerging risk earlier. So taken together, this gave us confidence that placing self-service checks in workplaces genuinely helped reduce barriers for men, routine and manual workers, and people who don't routinely engage in our preventative health services. Next slide. Risk and follow-up. One of the key questions was whether the model was identifying unmet needs and triggering appropriate follow-up. Across the pilot, 3,300 self-service health checks triggered a GP call to action, most commonly for raised blood pressure or BMI above 35. That's roughly 1 in 5 people who completed the kiosk check. Participants were asked whether they had a blood pressure check in the last 12 months. Amongst the 10,000 participants that responded to the question, 6,500 or nearly 2/3 said they had not, suggesting this approach reached people who weren't in routine contact with routine health services. Crucially, this project connected back to the NHS Health Check programme. Around 500 of those who were eligible went on to take a full NHS Health Check for our provider Health4U, showing us that self-service checks acted as a practical trigger to established clinical pathways. Next slide. So what we learned, one of the biggest surprises was how positively employers responded, particularly those who had previously been reluctant to host a face-to-face NHS Health Check. One example was Stagecoach East, the primary bus operator for Cambridgeshire. Uptake was far higher than expected, and they identified previously unknown risk amongst predominantly male sedentary staff. They became an advocate for the scheme and independently issued a press release on its success. Because checks were discreet and self-directed, men engaged without feeling judged or lectured. This all created a snowball effect, with repeat requests and new employers approaching us. We have now mainstreamed this model as our business as usual as part of our behaviour change service beyond the DHSC pilot. Final slide, please, Jez. So the big takeaway message is that GP-based NHS health checks remain the gold standard in terms of clinical depth, particularly around the blood tests and the opportunity for a two-way conversation about cardiovascular risk. What this pilot showed us, though, even high-quality offers won't reach everyone if access is difficult. For groups like men, routine and manual workers, access is often the main barrier, not lack of interest. The self-service kiosks are high quality in their own right, but they do something slightly different than the NHS Health Check. They provide a quick, accessible way for people to understand their risk and, where appropriate, act as a gateway into more in-depth conversations and health improvement services. That's me.
Brilliant. Thank you,
Yes.
Paul. That was absolutely fantastic and hopefully really helpful for everybody on the call. So I would now like to introduce you to John Ford, who is joining us from Solihull Council. So over to you, John.
Thanks, Jez, and thanks, Paul, for a really interesting opening presentation. Good morning, everyone. My name is John Ford. I'm a consultant in public health at Solihull Metropolitan Borough Council. We also participated in the workplace CVD prevention pilots sponsored by DHSC last year or the year before. And we took a slightly different approach to Paul, which is always good to contrast and compare two different models. We have a long-standing history of working with Jaguar Land Rover in Solihull. Much of that was based on recent experience through the COVID pandemic. We worked very closely with them then, and that relationship has continued and continues beyond this pilot as well. I think one of the things when the call for expressions of interest came or submissions was that we immediately had conversations. So my Director of Public Health had a director with the Chief Medical Officer at JLR about the feasibility. That all very quickly got agreed. And then we took a kind of program manager approach. We freed up some additional capacity within our department. My shout out to Manisha. Unfortunately, she's not here anymore, but I mean, as I say, she's not here anymore, I mean, she's not working anymore. She hasn't passed on anywhere. But she was the program manager, and we set up a project task and finish group that met weekly. So we're really keen from the outset to make sure that we had a good approach to delivering this model. We also wanted to make sure that we wanted to undertake a local evaluation as well, which I thought was really, really important, that complemented the national evaluation. So next slide, please, Jed. This is just a background to the impact of cardiovascular disease generally in the UK and its cost. We've all read the NHS strategy around a shift from treatment to prevention. I think the narrative and the rhetoric is good. I think trying to do it in practice has always proved challenging, as many of you will know. But we thought through this pilot was an opportunity to demonstrate a different model of reaching hard to reach groups. So next slide, please. Thanks, Jed. So our local objectives were to target working age men, especially production line staff at JLR, extend the data set to include lifestyle questionnaires like Audit C and GPAC around alcohol and physical activity. We also had trialled previously in another pilot the value of point of care testing. So actually negating the use of follow-up, having the test there and then and having test results available to the individual so the risk could be assessed. And then also integrating referrals to our local lifestyle services and also those services that were provided by JLR, which you'll hear about a little bit later. And also finally explore the feasibility of workplace and GP electronic data sharing, which has always been a massive challenge in terms of third-party delivery of health checks. Thanks, Jez. Here are some demographics of JLR and what we were trying to achieve and trying to hit those groups that we felt traditionally weren't taking the NHS Health Check up via their GP. Thanks, Jez. Next slide, please. So what we were trying to do around what we thought we wanted to achieve through this was early detection of hidden comorbidities, increased access of men of minority groups, point of care testing enabled same action, as I mentioned earlier, actually reducing loss to follow-up, which is really, really important because in the traditional delivery in GP surgeries, it takes generally 2 visits, and the second visit, you always have a bit of a drop-off. potential to improve workforce productivity and reduce sickness and absence. And it also aligns with Get Britain Working White Paper and priorities. And, there's a lot of emphasis on trying to get people back to work and also understand why people are sick and absent for a long period of time. Thanks, Jez. So some of the challenges, and Paul's already mentioned these, but short time frame, reduced target numbers. Originally, we were hoping to target 4,000 of the 9,000 workforce at JLR. That had to be readjusted. There are operational difficulties with JLR releasing production line staff. However, that didn't stop us having a sizable cohort in the end to base these results on. There was some initial confusion about the GP referral pathway after these tests, but again, through the task and finish group, we were able to work those through. And then data sharing GPs, I'm sure Sisu will go into this in a bit more detail, but that was the absolute game changer that made such a difference to this project when we were able to crack that very, very difficult nut. It was very, very helpful. And also, as Jed mentioned earlier, our partner Solihull in Solihull also came and put their shoulder to the wheel to enable us to make this a very effective delivery model. There are also issues about had we been clear on consent and GDPR issues, and again, through the task and finish group, we're able to iron out those particular difficulties. Thanks, Jez. So here are some of the lessons learned. I think really, really important from this from the outset. I think there was strong collaboration between JLR and the local authority that was based on a good, strong history previously. Again, the task and finish group worked exceptionally well together. I think there was a real commitment to working through some of these knotty problems that previously we kind of put in the too difficult column. I think that was really, really helpful to have that battle rhythm every week of having that team meeting, working it through, having action logs, all the tools that you would want to ensure a very smooth delivery of the project. The other thing, I'm sure JLR colleagues will talk about this in a moment, one of the things we felt was really helpful is not just to have the CV checks as a standalone thing, but actually to embed it in other wellbeing events for the whole of the workforce that JLR were putting on. And I think that was really a smart way of throwing the net wide and also destigmatizing the issues around men's health. Having on-site GP access also improved follow-up, and that was something that JLR worked with on Solihull and Sisu in terms of making that happen, and that again was a big game changer. And as I mentioned previously, the point of care testing does add real value in terms of reducing loss to follow-up, and that's a big thing with the NHS Health Checks. Thanks, Jez. Next slide, please. So cost and sustainability. Originally, we had the funding of 106k. We want to do 4,000 checks. That's approximately at 40k a unit cost. JLR contributed significant resources on top of that and support. I think if we were going forward, one of the things we would want to do is how do we manage those costs more effectively? So looking at single procurement framework and easier NHS data sharing. It's something that the NHS has tried for many, many years, and as a person who's trained and worked in the NHS for many, many years, gets frustrated at a lack of a national IT strategy. I know we were there previously with MP Fit, that fell at the final hurdle, but that does need sorting out. I think the other thing is understanding as a part of the interaction of the health check, the health literacy of the individual, so using techniques that people understand, teach back, have they understand their risk, what the next steps are, and that tracking and referral into support services, whether it be quit smoking services, physical activity, drugs and alcohol, that's really important too. So that whole wraparound thing and tracking that person's journey from assessment through to risk, through to treatment, to follow-up, I think is really, really important. And I think actually what this model demonstrates is a real opportunity of good value for return on investment in terms of, people who are not going to get sick later in life or in crisis, so hospital admissions or more GP treatment, actually getting treatment early, secondary prevention early, starting statins early, starting hypertensives early, all help to reduce the burden on the front door. But also from a JLR point of view, they don't have so many people with sickness and absence with chronic illness. Next slide, please, Jez. So in conclusion, I think what we've demonstrated through the data on this one, and I was absolutely delighted that our local evaluation was very robust, and actually from a national evaluation point of view, I thought ours was better. I have to say that. I think we did a great job in terms of understanding impact. I think we did demonstrate we were good at reaching hard to reach groups. I think the fact that we identified people, 1 in 3 of the people who came for the health check ended up having to have a referral. You know, we identified people at risk very early who previously had no signs or symptoms or were completely oblivious to their risk, which I think was great. And I think this model is scalable into a good prevention model. And also the notion of the way the landscape is changing right now around neighbourhood integration, neighbourhood plans, neighbourhood teams. I think there's a real opportunity to look at this model at scale, not just with JLR as a flagship employer, but also to their suppliers and the people who also are part of that larger network through small to medium-sized enterprises. So I'll end there. Thanks very much, Jez. Appreciate the time. Thank you all.
Great stuff. Thanks, John. Right, so I will now move on to, I guess, same coin, the other side of the coin in terms of perspective, which we have Carol joining us from JLR, who will talk a bit about what I guess, an employer's perspective was on the experience. So over to you, Carol.
Thank you, Jez. Thank you, John. You covered an awful lot of what's in my slides as well, but this is from the JLR perspective. So good morning, everybody. I'm Carol Pulfer, the Occupational Health Manager for JLR, and I'm really pleased to be here this morning to talk you through the journey that JLR went and how we did it and what model we followed. To be part of the pilot, it was crucial for JLR to have senior leadership buy-in to get a structured release plan for our Solihull manufacturing employees. That was a very complex, and a lot of negotiation had to happen to get that plan in place. But we did get a plan in place, and it was a successful plan. The pilot became part of a much wider strategy for JLR called the People Love Day, which continued throughout the year, and we delivered that in partnership with health partners. So thank you for that. Next slide, please, Jez. So that come through, yeah, thank you. So the model we adopted was within the wider wellbeing strategy that I just mentioned, where we adopted a 90-minute wraparound wellbeing session for every single employee that came to People Love Day. This included point of care testing, the CSU kiosk with the CVD checks, and also they had the opportunity to complete the British Heart Foundation review self-led CPR program, and then an opportunity for them to wind down, have some fun activities, like we had the Sims there, we had Blaze Pods, and we had lots of things where they could just have that time to enjoy the day, enjoy being part of the Wellbeing Day. And also within that fun, we did some more signposting as well as part of that 90-minute wraparound. Next slide, please. We'd like to say we adopted a gold standard end-to-end process. So the process for the employees started with a very simple People Love Day invitation. They were invited to come to the People Love Day, which was a standalone event in Castle Bromwich, because the Solihull plant didn't have sufficient space to hold it there. So each day, Monday to Thursday, we would ship the Solihull employees over to Castle Bromwich VIP Centre, and there they would go through the Wellbeing initiative, which included the Wellbeing section, D&I and the JLR purpose. Once on site, they would visit the Wellbeing section. They would have their point of care testing. Each employee was given a health metrics card, which was completed, and then they would go to the kiosk and enter that information into the kiosk. Following the kiosk, they would move on to a wellbeing physiologist that would go through the results with them. If needed, they would signpost them to their own GP, or they would have the opportunity to have an appointment booked within work time with the NHS GP on site at their Solihull plant. So that was an absolute pivotal part of this pilot for us. It was something we'd never had before. The employee would come to work as normal, but within their working day, without having to leave site, they would be able to access a GP. And once that GP had seen them, they could then start the journey with that GP. And as John said, we did have lots of challenges with data transfer, but that was eventually done, and we could transfer the data as we needed to. Could I have the next slide, please? So, as John said, unfortunately, due to some logistic challenges within JLR, we couldn't start the programme as early as we wanted to. So we had a much shorter period from January to March. But we did deliver 1,260 checks. And from those checks, 426, which is 34%, needed to be escalated either to the on-site GP or to their own GP. And the number of employees seen on site at Solihull by the NHS GP was 145. That's 12%, which is a signal of the unmet need within the workforce. So that again, that GP being on site was pivotal for us. The next slide, please, Jess. Over 100 conditions were diagnosed by the on-site GP. It's important at this time just to remember we're talking about conditions, we're not talking about employees. So it wasn't 117 employees that were diagnosed, it was 117 conditions. So for an example, one employee would have come to the GP's appointment and been diagnosed with pre-diabetes, high blood pressure, or high cholesterol. The three biggest causes were high cholesterol, overweight, and high blood pressure. The feedback that we got from the employees was that being able to visit the GP on their work site in their work time really helped them to understand their health condition. And these were a group of people that didn't really go to their GPs because of the time restraints and the shift patterns, remembering that most of JLR at Solihull are on a 3-shift pattern. So it was very difficult for them to access their GPs. And that feedback was constant from the GP on site and also from the employee. So just to summarise really the lessons learned, significant upfront investment required. We had, sorry, was that a question? No, okay. We were fortunate that we had our Centre for Wellbeing team already in place from health partners, and they supported the pilot. But even with their support, we had to recruit staff members, try and train them up to support parts of the delivery. And then there were the little hidden costs, such as clinical waste and printing, that we hadn't really first thought of when beginning the pilot. But then, obviously, when we were in the planning stage, these things started to appear. The other essential part of the pilot was our partnership with health partners. As you previously said, Jess, their delivery was essential to the success of it. So the key deliverables achieved was ease of access, early detection, and access to a GP on site. Our quality of experience and the impact beyond absence, which CVD prevention and future sickness reductions, and what would have been the cost of us doing nothing. So 117 illnesses, disease have been identified, and we've started medication for those people, so they will remain in work, and hopefully that will reduce future absence. The delivery model shifted the CVD risk detection from reactive healthcare to proactive workforce prevention. We engaged with a workforce that is very difficult to engage with. Release of a big manufacturing plant is a huge problem for us with any intervention that we do. So having that leadership at the very beginning was one of the main reasons for success, because obviously if we can't get them off the line to come to these interventions, we're not going to get the results, and we're not going to get the early detection that we got. So I think that's a very brief summary from JLR.
Brilliant. Thanks, Carol. That's really, really interesting, and some really good in-depth information there about how the project worked. I'm sure that lots of claps coming up there. So we will obviously have a few questions coming through in the Q&A, but I just would like to give a little bit of information and, I guess, bit of data from a CC perspective, and Sam will also talk a little bit about, I guess, how we're reacting to some of the learnings from this. Just wanted to share a few headlines, because we did work with Solihull, and we did work with Cambridgeshire, but we also worked with a few other local authorities. Southwark, who we've worked with for many, many years, and who published an evaluation of some of our work in the community a couple of years ago, and Tower Hamlets in London, and a couple of other local authorities as well. We have got some interesting data here. The full reporting that we typically provide is much longer, and typically a report that we provide is around 60 pages long. And just as an offer for people on the call, if anyone is interested and would like to look at the data in more depth, I'd be very happy to share. I guess just sort of looking at the pilot objectives, and did CSU achieve the pilot objectives either at a local level or across all of the pilots? We feel that we did, and one of the first parts is just looking at the business case and understanding the benefit to businesses. So employers do want to invest in prevention. We absolutely see that in the work where we work directly with employers, but they need credible data to justify it. As part of the pilot, we delivered detailed reports to the employers that enabled data-led strategic decisions, which also is clearly a key requirement to encourage further investment. And across all of the pilots, our modelling indicated a combined £23 million of annual lost productivity, so an average of £1,000 per employee. We also saw strong evidence of unmet need, particularly in the front of the line operational workforces. So around 20% of checks took place between 6 p.m. and 8 a.m. A lot of night shift workers, particularly in the Cambridgeshire pilot. And that sort of reflects the shift patterns and the reality that many people just can't access services during normal hours. These two data points together make the case that workplace checks can support productivity and resilience by reaching people where they and when they are. The second key point of the pilot really was to test feasibility. And the pilot showed that workplace delivery is practical because it reduces friction for both employees and employers. And we saw consistent reach across demographics and deprivation. And the model works in different settings because it can fit around operational constraints. Key learning here was that where employers had strict time limits, a quick workflow made a difference. So in Paul's examples, where it was a multi-employer delivery, the approach helped engage employers who could not take staff off production lines for more than 5 minutes. We saw them work with food processing, some big household names, retailers, a range of other really interesting organisations. And that enabled us to scale without relying on repeated nurse-led clinics at every site, which in some cases, the team at Cambridgeshire found they just simply couldn't get access to some of these employers previously. And the third key part of the pilot's objective was to drive detection. So the aim was to reach people less likely to take up traditional checks, and key targets were people, men, younger workers, core 20. And that's critical because we're seeing meaningful risk earlier. So, for example, and this is from our total data, for people aged between 30 and 40, we're typically seeing around 10% of individuals already presenting with high blood pressure and 67% with a BMI above 25. So we are absolutely seeing risk present earlier. And we've got some really quite startling data in some areas of the country for people in their early 20s as well. And another example is we're seeing vaping prevalence growing quite considerably, particularly amongst younger women. Overall, the pilot demonstrated clear business benefit. It was practical, delivered at scale, and a strong detection in working age populations who, as the guys have already identified, often miss traditional routes. Perhaps critically, where we were able to test impact, and we did return to some locations, particularly in the Cambridgeshire example and a few locations in Southwark as well, we saw real health improvement. The data that we've generated from this pilot specifically, we saw 43% of individuals who did a health check at the start of the pilot, who presented with blood pressure, had reduced it by the time we'd retested at the end of the pilot and had reduced it to a healthy level. That is quite a high number. Our typical number across all of the work we do in workplaces is around 28% reduction. What's really interesting is when we compare to our data in public locations, it's actually higher. And I think there's a bit around the behaviours that are driven by doing workplace health checks, which I'll touch on in a moment. So one of the key pieces of work that Southwark Council did when they did the evaluation of our project a year ago was using the COM-B model, which I'm sure the vast majority of people on the call are familiar with. And so we tend to look through the lens of the COM-B model, but we also survey all of our users after they've completed the health check. So typically it's after 48 hours and then again after 12 weeks. And in some cases, we do ad hoc surveys when we're looking to get additional data. And we've completed over 2,500 surveys in recent months. So some really, really interesting data coming through. And we're seeing a positive psychological effect from doing a health check with enhanced impact when delivered at work. So workplace delivery removes friction, it turns prevention into the default, and as Paul shared, the multi-employer model engaged employers who could not take staff off production lines for more than 5 minutes. And in COM-B terms, this is reducing time and access barriers and increasing uptake without people needing to try harder. And that's kind of, again, that sort of hard to reach population, which people have said to me recently is actually more about yet to reach. Motivation is the sort of really key piece to look at as well. And what we're seeing is that self-initiated checks feel self-directed rather than prescribed, supports autonomy and engagement. I think people seeing their numbers creates a motivation window, and with signposting referral pathways, we can convert that into action. So from our survey, 73% of people saying that the check positively influenced their health decisions, and that's within the 48-hour window, really important to drive that change. 85% said it encouraged healthier choices at 12 weeks. We've also seen some really sustained lifestyle shifts aligned to the CVD prevention priorities. The 12-week survey point, we're seeing 2/3 of people have improved their diet, 60% have increased activity, and 25% crucially have reduced alcohol. And I know Paul at Cambridgeshire is looking at that specifically to look at targeted interventions at the local level. So I'm somewhat conscious of time, so I'm going to strip through so we've got a little bit of time for Sam. But I guess the workplace model also strengthens the intention to action. We're seeing that happen with JLR in terms of number of people seeing immediate on-site escalations. And what it's doing is it's driving equity by design by reducing access to various working age groups. And one of the key things we're seeing from the surveys is 86% of people who've indicated ethnicity as Black have reported a positive influence, 81% of Asian respondents, which is significantly higher than our white respondents at 70%. So again, the core 20 plus cohorts being really positively impacted. Men specifically are indicating that they have a preference for a self-service check, 48% of men versus 11% preferring a clinician-led check. So I'm going to hand over to Sam now. He's going to talk a little bit about what we do and what our model is, and hopefully we'll get a bit of time for the Q&A as well.
Lovely. Thanks so much, Jez, and thank you to all of our speakers. This is your 3-minute warning, speakers, that we have lots of questions for you all in both the Q&A and in the chat. So please do jump in now and have a quick look. I will facilitate those in a second. And just for all of our attendees, if you do have any more questions to ask, please put them in the chat now, and we'll come to those in a couple of minutes' time. I'm Sam, I'm the CEO of Solihull Health. Just going to talk really quickly in terms of some of the learnings that we've taken out of this programme, but also more broadly out of our work across both NHS and public health, looking at population health screening and triage models, but also in the work that we do in workplaces with employers, where we're sort of leveraging a different context to deliver population health solutions as well. We are a preventative health ecosystem. We stretch all the way across from initial engagement of the individual, facilitating them to monitor their health using either the self-service health stations that we've talked about today, or in fact they can also do an online health risk assessment in our app as well. Typically, though, what we find is that the placement of the health stations, which can be placed in an array of different public and workplace locations, is what opportunistically grabs the person and engages them in that first health interaction, and then increases their health literacy by providing them with the health data. So to give you, we've talked about lots of examples today of where health stations have been placed, but other non-typical locations that we've done recently to really try and grab particular populations, a mosque in Cambridgeshire, working with Cambridgeshire City Council, and the Latitude Dance Festival, if you sort of look at extreme ends of the scale as to where and how we can opportunistically engage people. These 4 verticals that we have at Solihull are how we are growing out our platform and responding to the needs, both in the NHS and public health strategies, but also in terms of how we can support a variety of programmes, be that future neighbourhood strategies, be that work well plans, be that NHS digital health check delivery as well. So a large part of what we do is also facilitate personalised journeys. Both the health station and the platform that sit behind it are very flexible and smart, so they allow us to empower self-care in a range of different ways, but then also triage and refer and proactively nudge people into follow-on pathways and transfer of data. So as an example, that might be they trigger a risk or an eligibility criteria, and we triage them into a local health and wellness service, as we've talked about in a couple of our models today, all the way up to transferring their data to a GP for a GP initiated interaction as well. And underneath all of this, we provide both the user significant amounts of data to support them in their health journey, but also to our stakeholders, as Jez just mentioned, we are providing significant amounts of anonymised and aggregated population health data. Everything from the engagement of the users to the demographics, to their health results, to the change in their health results over time, how that's impacting productivity, how that's comparing with national benchmarks, and so on. We just go to the next slide, please. So we really are trying to get that initial engagement point and then be as impactful as possible. Just some of the things that we have launched in recent times to both increase reach and accessibility include multi-language. So the platform is available today in 17 languages, and new languages coming on board all the time. We have the mini health station, which is also available to go out to smaller, more remote sites. We have use cases across oil rigs for that, for example, as well as smaller workplaces, as well as health check buses, health and wellbeing hubs where they're being used today. And more recently, as we talked about in the Solihull and JLR, we can do a full digital version of the NHS Health Check with pathology results incorporated into that. We talked about the challenges. John mentioned them in terms of the transfer of data. We now have a couple of different mechanisms by which data can be transferred from the user health check to either a health and wellbeing service or to a GP, and happy to pick up on the details of those with anybody who'd like to know more. There will be even more options coming online through this year as well. We do lots of population health data for our clients as well, usually in anonymised and aggregated, but we can also provide much more detail for other evaluations and analytical purposes. Next slide, please. I'm just going to touch very briefly then on what's coming next. So some of the things that we have taken away from this programme and from other ones, building on the aspects that Sisu Health deliver today. But what we're really keen to explore and to understand from everyone that we currently work with and all of the people on the call today is what would be most supportive and impactful in terms of enabling your strategies and your programmes and eventually having the most impact in your community. So everything that we're looking at in terms of new data products and integrations, new end-to-end case findings, reacting to some of the new hypertension, obesity, diabetes, and so on coming out, as well as new health and lifestyle additions that we can self-empower to an even greater extent and really support our users, whether they choose to access an intervention or not, to change their behaviours and improve their health. That's all I'm going to say. I'm going to thank all of the speakers now, and we're going to come on to some of the questions. I'm going to come to Paul first, if I can. We had a whole array of questions come out of the back of your presentation, which I think people found really, really interesting. Probably just to wrap them up, Paul, perhaps you could just talk for 1 or 2 minutes a little bit more about the how it was implemented and what the model was that you sort of used in terms of both the health check, but also sort of the number of health stations and so on that were being implemented.
Okay. I think what's the kind of surprising element is how the programme picked up momentum quite quickly. We started in October, so just before Christmas, and by the time we got to Christmas we were way down in the numbers that we expected, and then as soon as his Christmas hit, it just exploded in terms of the number of checks we were doing. So we were surprised at how we were worried that the program wasn't working, and then all of a sudden it kind of boosted in. So I think once it picks up momentum and we got the pattern correct when we were approaching businesses about what the model could offer them and the benefits to them as a service and to their staff, I think that kind of learning as we took on, we were learning as we went along, really benefited upselling thereon. So post-Christmas, between Christmas and May, we did probably 3/4 of all of the checks we were doing. And I think that model is good. I think the point I want to make is that the health check and the kiosk health check is an intervention in itself. Even though some people just see it as just a series of questions on a screen, it did have a kind of behaviour change mechanism to it. People did act on the results either by going on and having a full NHS health check at our provider, and that's the only data we have. We don't have the data about how many people went and had their check up their GP, so we don't know if it triggered people to go and contact their GP to have a check. We only know the ones that went through to our community provider. So I think it acted as that first point of contact for a lot of people that wouldn't have had the check or thought about having their blood pressure taken unless it was put in front of them. And I think that model for men and routine manual workers was the kind of the biggest coup, really, because it surprised us how quickly uptake escalated.
Yeah, thank you, Paul. And I think just to add to that as well, we had a question about what does the user see in terms of results. So just to cover that off very quickly, as the user does their self-service health check, they are supplied with both their results and some brief information around recommendation and any signposting or next steps that might be available to them. And then they also have the option to log into the Sisu Health app, where they can track their results over time, and there are far more resources available to support them in lifestyle improvement, but also understanding their health metrics as well. Great, lovely. I know, John, you've already answered a couple in the chat. You've been very sort of efficient, but would you just sort of like to come back to a couple of the questions that were there for you around sort of model as well?
Yeah, sure. I think one was about return on investment and costs. I mean, I think we have to be honest in as much, particularly when in something like this is a national pilot and to some degree you're demonstrating proof of concept. So investment is always going to be that much higher. And I think as certainly within the group, within the Solihull group, you know, of all the organisations, I think there was a general understanding that actually if you were to put this on a more sustainable footing, on a more permanent footing, that you would be able to reduce those costs. You know, that might be through procurement of certain bits of kit, or actually just a long-term contract would, those sorts of things would make it more effective to commission. So although the original unit cost was £40 per head, it was significantly higher than that. We know that. But I think there is potential to look at reducing that cost and making it a far more sustainable model. The other bit was about ethnicity, and I've gone back to the questionnaire again, said, yeah, actually, we were very good at identifying, or actually from global majority individuals, we were able to get those in for their health checks. I think 26% off the top of my head, from the sample size that we had. That's significantly higher than you would normally get for an NHS health check in Solihull. So I think in terms of identifying, one, men of a certain age, two, other groups who are at risk, it's an effective model. And as we saw earlier, over 10% of those identified had a Q risk above 10%. So and were completely asymptomatic. So in terms of sort of the kind of case finding that you would want to get from an efficient health check, I think it's a model that with a little bit more tweaking would work. And obviously you've touched on the data transfer, which I think is critical in terms of follow-up. I think some of the user feedback, I think probably Carol and other colleagues were probably better placed. That by and large, I think the feedback from the model was very well received. I think people were very happy with the work, the work that had gone on, and actually, in some respects, had some really nice comments about, thanks very much. I didn't realise I had a high blood pressure, and now I'm on treatment. So all of those things, that word of mouth by the workforce, is also something really, really positive to hold on to. Thanks,
yeah,
Sam.
no, I think that's a great point. Thank you, John. And I believe, although I would look to Carol and Chris, we got a net promoter score, which is a sort of score as to whether you would recommend the service, I think, well above sort of global best practice. I think perhaps even up to sort of the 70s to the 80s in response from JLR employees as well. We are running out of time. I've just got one quick question, the last one I can see from Luke, about health literacy and how we saw people impacted by digital poverty. We heard quite a lot from the speakers through their presentations around how this was very effective in reaching those in lower socioeconomic groups, so those living in more deprived areas, but also from an ethnic minority groups. But I think it is really important that we also address the sort of digital inclusion point as well, both through these programs, but I think also in a lot of the other work that CSU Health does, where we do work with populations who are impacted by digital exclusion sort of aspects. So, for example, we work with the homeless. You are able to use the self-service kiosk without a mobile phone. We do ask our users to give us an email address so that we can then link them back to data. But what we do find is, because this isn't a mobile-based delivery, that we are able to engage those who perhaps might be excluded by mobile and app only. But I think it also comes back to Paul's very well put point earlier, which is there's no one size fits all, and different populations are going to respond in different ways to different models. And much of this today is about the ecosystem and bringing together different partners to ensure that we increase access and can have that positive impact for as many people as possible. And I think that's probably where we're going to have to leave it. Thank you so much to everybody who has attended today. We really appreciate your time. We know you're all incredibly busy, and there's an awful lot going on in this space at the moment. Thank you again to all of our presenters, to Paul, to John, to Carol, and also to Chris from Health Partners, who played a pivotal role across the programmes. Thank you to everybody, just echoing Jez's thoughts earlier, who was involved in the programmes. We are very proud, I think, across all of the partners to be able to say that we've had a significantly positive impact on a significant number of individuals through the delivery of this programme. There is a separate evaluation ongoing on the CVD workforce programme. I think there's been some initial some findings released, which you are able to access, and we can help you find those if you would like to. This will be available on a recorded basis, and we do have a follow-up webinar coming in March, which will focus more on neighbourhood strategy if people would like to get involved in that. My final thanks to the CSU Health team, who've done a fab job in bringing all of this together. And I'll just pass back to Jez to do one sort of final closeout, please.
Brilliant. Thanks all. like we've indicated, we will be sharing the slides with everybody. We also have an evaluation report that John wrote for the project with JLR, and we have some other evaluations which may or may not be of use. And if anyone who is keen to see a more detailed report, either from that piece of work or other pieces of work we've done, please drop us an email. I'll put the information in chat, but when we send over the packs, you'll have our details there. So look forward to speaking to anyone who's keen to follow up. Thanks all.